Good afternoon and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model System, or what we call MINSCIMS for short. Thank you to everybody for joining us today. MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDILRR, through their Spinal Cord Injury Model System program. The purpose of the SCIMS is to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injuries. Next slide, please. MINSCIMS represents an exciting partnership among the following Minnesota institutions: Courage Kenny Rehabilitation Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and the University of Minnesota in Minneapolis. Next slide. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injuries, including emergency medical, acute care, acute rehabilitation, and post-acute services. My name is Kimberly Mondin, and I will be the moderator of today's session. I'm an associate professor and the vice chair of research in the Department of Rehabilitation Medicine at the University of Minnesota Medical School and the project director of the Minnesota Spinal Cord Injury Model Systems. Next slide. A few housekeeping notes before we start. The University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the MINSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the Q&A function. If you have technical or logistical questions, we ask that you please submit those in the chat to Dan Kelly. We extend a huge thanks to all those who work behind the scenes to make these webinars possible. Next slide. The title of today's presentation is Exploring Patterns of Resilience After Spinal Cord Injury, and the speaker for today's webinar is Dr. Angela Hanks Philippus, or Angie. Angie Hanks Philippus is a research project specialist 2 in the Department of Rehabilitation Medicine at the University of Minnesota Medical School. She has over 15 years of specialized experience managing and implementing research studies involving individuals with neurologic injuries such as traumatic brain injury and spinal cord injury. Throughout her career, she has worked with hundreds of participants who have candidly shared their thoughts, feelings, and perspectives on adapting to injury. These interactions sparked her curiosity in psychosocial research and ultimately shaped her current focus on identifying psychosocial factors that enhance participation and lead to positive psychological outcomes after neurologic injury. Her overarching research goal and career goal is to improve the quality of life for individuals with neurologic injuries by advancing measurement techniques and developing effective psychosocial interventions. It is my distinct honor to introduce Angie today, as she is my mentee and has worked with me for 8-ish years. And I'm excited for her to transition now to becoming my colleague. So Angie, I will hand it over to you.
Thank you, Dr. Mondin. And thank you all for joining today. I'm excited to talk to you about my dissertation. This is Exploring Patterns of Resilience After Spinal Cord Injury. I do not have any disclosures or conflicts to disclose. So the objectives for today are: first, I'm going to provide a high-level summary of resilience literature as it relates to spinal cord injury. Then I'll describe the aims and study methods for my dissertation work, present my results, and then finish up with a discussion and future directions. So starting off with a high-level overview of resilience in spinal cord injury. Early resilience researchers like Maslow and Werner challenged the traditional disease-focused model of psychology by highlighting the positive aspects of the human experience. And their work really paved the way for the emergence of positive psychology, which was championed by Marty Seligman. Seligman's vision for positive psychology was to shift the field's focus from merely repairing the worst things in life, but to also build the best qualities in life. And this new perspective really emphasized studying the factors and processes that allow individuals not just to cope, but to actually thrive in the face of adversity. Resilience in particular became a key construct within positive psychology. Researchers began to explore the personal characteristics and environmental factors that enable some people to successfully navigate and even grow from challenging life experiences. So as we move forward through this today, we're going to take a closer look at how the concept of resilience has been defined and studied with a specific focus on its relevance to individuals who live with spinal cord injury. And then this sets the stage for the research I'll present today, which aims to identify distinct resilience profiles within the spinal cord injury population and to explore their associations with various demographic, injury-related, and psychosocial factors. All right, so what exactly is resilience? So currently, there's no universally agreed upon definition of resilience, but most of these definitions involve some notion of a successful outcome in the face of an adverse event. So as you can see in the definitions presented here. Some believe that resilience is a fixed personality trait and it's stable over time, while others, including the American Psychological Association, conceptualize resilience as a combination of skills, resources, behaviors, and actions that can actually be cultivated and altered over time. Spinal cord injury then is broadly defined as damage to the spinal cord or to the nerves at the base of the spinal canal, which results in permanent or temporary loss of motor and or sensory function. Traumatic spinal cord injury, which is the focus of my study, occurs as a result of a sudden blow to the cord caused by some external force. And common traumatic etiologies include motor vehicle accidents, falls, sports-related injuries, as well as violence. So as a result of spinal cord injury, people may experience complex changes in physical, psychological, and social functioning. For instance, people living with spinal cord injury are at a greater risk of secondary health conditions, mortality, psychological morbidity, and lower life satisfaction. Further, unlike other adversities a person might face in their lifetime, including a disability, including spinal cord injury, is associated with ongoing challenges and potential setbacks. And this can have an additive and reciprocal effect for the person who lives with spinal cord injury. And as you might imagine, people with low resilience, the psychological and physical health consequences can be detrimental. Despite this, many individuals go on to demonstrate subsequent positive psychological health and satisfaction with life, which to me sounds a lot like resilience. Looking at the concept of resilience in the spinal cord injury population, Scott McDonald and his team conducted a scoping review in August 2019 to synthesize existing literature. The inclusion and exclusion criteria for including studies in their review are on this slide here. So using these criteria, McDonald and his team identified 40 studies to review. And then in June of this year, I extended the review using these same criteria and came up with an additional 39 articles that met the criteria, and I also reviewed them for my current study. The articles largely fall into one of four categories. So measurement, factors associated with resilience, resilience and psychosocial outcomes, and resilience interventions. So let's start off and talk a little bit about measurement. One of the most commonly used measures of resilience, both in and outside of the spinal cord injury population, is the Connor-Davidson Resilience Scale, or we call it CD-RISC for short. It was developed in 2003 among people in the general population. And these authors conceptualize resilience as a personal quality, which reflects the ability to cope with stress. So on this slide here, I've shown you the measure itself and then highlighted a few of the items from this measure. So a couple of them, I'm able to adapt when changes occur. I can deal with whatever comes my way. I'm able to handle unpleasant or painful feelings like sadness, fear, and anger, and so on. The Brief Resilience Scale, or BRS, was also developed outside of the spinal cord injury population, but it's also commonly used in spinal cord injury research. So Smith and team defined resilience as the ability to bounce back from stress. And they sought to develop a very brief unidimensional measure to assess resilience in this way. And here are a few of those BRS items. So for example, I tend to bounce back quickly after hard times. I have a hard time making it through stressful events, and I usually come through difficult times with little trouble. Victorson and colleagues argued that a resilience measure specific to spinal cord injury was needed, as the highly disruptive and sudden nature of injury is vastly different than developmental transitions. And that's where most of the resilience measurement development is rooted. So in response, they developed the Spinal Cord Injury Quality of Life, or SciQual, Resilience Scale in 2015. Based on the operational definition by Wendell, where resilience is defined as a process of adaptation to extreme stress or trauma, and it's influenced by a person's psychological resources, life experiences, and the environment. And to date, this is the only resilience measure that exists developed specifically for individuals with spinal cord injury. So a few of these items include I was confident I could overcome my limitations. I felt good about how I coped with my injury, and I found new things to enjoy. All right, factors associated with resilience and spinal cord injury. So research has identified several key factors that contribute to a person's ability to adapt and thrive in the face of adversity. These predictors of resilience can be broadly characterized into three main areas: demographic characteristics, injury characteristics, and psychosocial factors. So while the evidence is somewhat mixed when it comes to the demographic and injury-related factors, the literature consistently highlights a strong influence of psychosocial factors on resilience among people with spinal cord injury. Specifically, individuals who report fewer depressive symptoms, higher self-efficacy, and greater social support tend to demonstrate greater resilience. There's also some indication that employment and lower levels of pain might also be associated with increased resilience. Now let's talk about resilience and psychosocial outcomes. The growing body of research suggests that resilience might be a strong predictor of positive psychosocial outcomes. Resilience has been linked to fewer symptoms of depression, greater quality of life, and enhanced social participation. Resilience has also been associated with post-traumatic growth, reduced pain, and improved adjustment to the injury. So while these findings are promising, we do have to temper our interpretations. The majority of these studies that we reviewed were cross-sectional in nature or qualitative, so this limits our ability to infer causation or directionality of these relationships. Resilience interventions. Well, there's not that many out there. Three that I could find. So starting with this first one on the left, Allina and colleagues conducted a mixed model feasibility pilot study. So it only had 11 participants of a web-based self-management program aimed at increasing knowledge and skills required to independently manage spinal cord injury. Feasibility, self-efficacy, and other secondary conditions, including resilience, were assessed both pre and post-intervention. Changes in resilience scores from pre to post intervention were not significant, but they trended towards significance. And again, just remember, this was a pilot study, so they weren't powered to find significance. In another pilot study, so the one in the middle, by Hahn, so the 10 people were included in this one, they investigated the impact of a psychoeducation and mindfulness intervention on psychosocial outcomes, including resilience. They did not find a significant change in resilience from pre to post test. However, they did observe a medium effect size. So again, not powered for, to be able to make conclusions, but the fact that there was a medium effect size lends itself to further study. And then finally, on the right, Guest and colleagues conducted a prospective quasi-experimental group cohort design, this time with 88 people, so a pretty big sample size. And they were investigating the efficacy of improving resilience by adding cognitive behavioral therapy group cognitive behavioral therapy to routine psychosocial rehab. The control and experimental group were assessed at 3 time points, so at the admission to rehab, at discharge from rehab, and at 6 months post-discharge. And they were measured on self-efficacy, resilience, and symptoms of depression and anxiety. Results of Mancova indicated no significant differences between the 2 groups on resilience over time. Also, results of growth mixture modeling revealed no differences in resilience trajectories either between the control and experimental group. Notably, the authors highlighted the importance for future researchers to utilize sophisticated analyses to identify heterogeneous response patterns rather than relying on multivariate analyses that evaluate both within and between group changes. So to answer this call to action, I proposed using latent class analysis, or LCA, which is a person-centered statistical approach to identify underlying subgroups or classes of people with similar response patterns to a set of variables. Perhaps identifying latent subgroups of resilience can lead to refined measurement tools and the development of more tailored interventions. So the overall objective of my research is to use latent class analysis to identify subgroups of people with spinal cord injury by their resilience response patterns, and then explore the association of these subgroups with demographic, injury-related, and psychosocial factors. Before launching in, I want to point out that my work is grounded in the conceptual framework of resilience that was proposed by Wendell, who suggests that resilience requires a significant adversity, the presence of psychological resources to offset that adversity, and personal and environmental factors that enhance the likelihood of that bouncing back. So this is my conceptual framework for the proposed study. We're going from left to right. So spinal cord injury is the adverse event. This event then impacts a person's psychological resources, life experiences, and environment. And in turn, these factors impact resilience. Given the multiple factors that play into resilience, there's likely different paths to experiencing it, which is indicated by the 3 classes on the right-hand side. Then I hypothesize that these classes are going to differ in psychological resources as represented by that bidirectional dashed orange line. All right, on to describing the study aims and methods for my study. To address the overall objective, I have 3 specific aims. The first aim is to identify subgroups of people with spinal cord injury based on their patterns of resilience responses. And I found a great visual from an allergy study by Amaral and colleagues that presented a graphical representation of a latent class analysis. So I thought it'd be helpful to kind of create my own visual. And what you see here is an adaptation of their graphic that represents the hypothetical findings. So on the left, you can start with, you start with the population sample. Then through the latent class analysis process, classes are identified by patterns of responses. In this hypothetical case, there were 3 classes identified. Then individuals are placed into each class based on their probabilities. So you can see differences in the classes by how they experience resilience. So in other words, how they respond to each of the 8 resilience items. For instance, class 3 appears to experience resilience by utilizing all 4 methods to a high degree. So the methods being positive appraisals, action-oriented, coping strategies, and self-efficacy. Class 1 appears to experience resilience through action and less so through the other various methods. And then class 2 in the middle appears to minimally utilize any of the methods, thus they may experience less resilience. All right, moving on to aim 2, the aim here is to examine demographic, injury-related, and psychosocial characteristics that are associated with the subgroups I identify. All right, back to the hypothetical scenario. So thinking about aim 2 here, We'd essentially be looking at the different classes to see if there's any distinguishing factors that stand out between groups. And in this case, it might be important to know how class 2 presents, so we can flag those people and target them for resilience intervention. And then the third aim is to investigate the relationship between the subgroups and psychosocial outcomes, including quality of life and symptoms of depression. Back to the scenario. Aim 3 looks at the relationship between each of the classes and those important outcomes. So in this scenario, it would be important to know which class experiences positive psychosocial outcomes. For instance, if people in class 1 experienced the greatest quality of life, perhaps it's due to their action-oriented approach to dealing with adversity. Or perhaps in class 3, they experience the highest quality of life and the lowest depressive symptoms, which may mean that people who utilize all resilience strategies have better outcomes. So this information is critical for the development of targeted interventions. To address my study aims, a retrospective cross-sectional design was used to analyze data collected from people with spinal cord injury who are included in the National Spinal Cord Injury Model Systems, or SCIMS for short, database. So here you can see the SCIMS inclusion criteria. And the database is managed by the National Spinal Cord Injury Statistical Center. And every 5 years, the data center publishes a free publicly available de-identified data set, and this is the data set that I use for my study. This figure here shows the breakdown of how many people are included in the public data set as of September 1st, 2021. Each box to the right shows the number and reason why they were excluded from my final data set. Analyses were performed to compare the demographic and injury characteristics of people included versus those not included in my data set. And we found that people who were included had a greater proportion of younger people in the data sets, people with incomplete injuries, married individuals, and people retired due to disability. No sex differences were observed between those included and those not included. Here are the variables I used for my analysis. For demographic characteristics, I used current age, marital status, employment status, and sex. Then for injury characteristics, I used the time since injury and injury completeness, which I determined by the level of neurologic impairment as defined by the NSCI exam that was done at rehab discharge, hospitalizations, and self-perceived health status and self-care behaviors. And self-care behaviors was assessed by the Sci-Fi Independent Self-Care Subscale. For resilience then, I used the 8 items of the Sci-Qual Resilience short form. And for psychosocial functioning, social support was quantified using the social integration subscale of the CHART short form. Living situation was collapsed into private residence, group living, or experiencing homelessness. And symptoms of depression were assessed using the PHQ-9, and quality of life was assessed using satisfaction with life scale. So here's what our final sample looked like in terms of demographics. So most were male, slightly more than half were 50 years of age or older, slightly more than half had incomplete injuries. Most were not hospitalized in the prior year, and most rated their health status as good compared to not good. Further, most of the sample was either married or single and either unemployed or working or going to school. The far majority of people were living in a private residence. The Sci-Qual Resilience total score indicates that majority of participants scored in the average range on the measure. Most scored average in terms of completing self-care activities. Most people felt slightly satisfied with life and self-reported very few depressive symptoms. The median time post-injury was 11 years, and overall 75% of people rated high or very high levels of social support. All right, on to statistical approach and the results. So starting with aim 1, again, the purpose was to identify subgroups of people with spinal cord injury based on their patterns of resilience. So in order to do that, polytomous latent class analysis was used to identify those latent classes. And we did so based on their patterns of resilience using those 8 items of the Sci-Qual Resilience short form. So latent class analysis assumes that there's unobserved or latent subgroups or classes that exist and can be identified by similar response patterns or distributions across the observed items. So to this end, we used a 5-step process shown here. And here's the results of A1. So I could go into all the fun statistical details here, but I'm going to breeze through it so we can get to the good stuff. But if you have any questions about the methodology or stats or particular results, I'd love to talk to you about it offline, and I'll present my contact info at the end. But just so you know, everything was conducted using M+ version 8.1 with base program and a mixture add-on. So first step, I fit models to the data ranging from 2 to 8 classes. And briefly, we found that the model fit statistics are best for a 3 or 4 class solution. And this elbow plot kind of confirms that and indicates that a 3-class solution might be optimal. So, you know, together these findings, it appears that either a 3 or 4-class solution would best fit the data. So next, to decide between the 3 and the 4-class solution, which one we wanted to go with, we inspected item response patterns within each class, and that's depicted here. So on the left is a 3-class solution, and on the right is a 4-class solution. The rows represent each resilience item, and then below it, each of the response categories. So to avoid getting too much into the weeds here, I just want to point out this nice gradient pattern that you see in each the 3-class and the 4-class solution. So class 1 has the highest probability of an always response for each one of those items, and that's indicated by the darkest green. The next class has the highest probability of an often response, and each class thereafter has a greater probability of a lower response to each item. So given that both solutions followed that same nice gradient response pattern, we went on to test each model for configural invariance, and we used 2 variables that we selected a priori, sex and age group. So configural invariance is really important in that when you say a model is invariant, it means that the classes that you have identified mean the same across the variable that you're testing. So this here is the 4-class model looking at response probabilities by male and female. So you can see that we've lost that nice gradient pattern that we had before. So this is a major issue, meaning there's a difference in response probabilities between males and females. So this solution cannot be interpreted the same across sexes. So we wouldn't want to select this solution. So then we tested the 3-class model and found that it is sex invariant. So you can see that nice step up gradient pattern again. So the classes mean the same thing when you're interpreting them for males and females. And we repeated this step for age group as well. And again, looking at the nice gradient pattern, we can say that this is also age invariant. And so this is a major strength of the 3-class model. So this is the model we move forward with. Next, I convened an expert panel comprised of clinicians with spinal cord injury expertise, an individual with lived experience, and statistical and methodological experts. And we were all tasked with naming and labeling these 3 classes that we just identified. And the panel all agreed that the graded pattern of resilience that we found has clinical utility. And after reviewing the data and discussions, we creatively named the 3 classes high resilience, medium resilience, and low resilience. Okay, so now that we've identified our 3 resilience classes, we can move on to aim 2. And again, this purpose is to examine demographic, injury-related, and psychosocial characteristics that are associated with each of these subgroups. So using those 3 classes, a series of polytomous logistic regression analyses were conducted to identify significant factors that are related to class membership. And the factors that I evaluated are included on this slide. And we used a 4-step approach that is described here. And here are the results. So these are bivariate analyses, and they revealed that the following covariates that I have listed here have a significant unadjusted relationship to resilience class membership. So then I use all of these variables in subsequent multivariable polytomous regression modeling. All right, so when we put all those covariates together, including our class membership, here are the results of the final multivariable Philippus regression analysis. Let's try to step through this. So this is presenting the odds of having low resilience class membership compared to having high resilience class membership. So females had 8% greater odds when compared to males of having low resilience class membership. People unemployed had 12% greater odds of having low resilience class membership. People who had a good self-perceived health status had 56% lower odds of having low resilience class membership. Self-care behavior, so for every 1 unit increase in self-care, they had a 3% lower odds of having low resilience class membership versus high. And time since injury, for every 1 year increase in time post-injury, there's a 1% decrease in odds of having low versus high resilience class membership. So now I'm making the comparison of the odds of having medium resilience class membership versus high. Females, 13% greater odds of having medium versus high class membership. People who were younger had 11% greater odds of having medium versus high class membership. People who were unemployed had 10% lower odds of having medium versus high. People with good health status had a 21% lower odds of having medium versus high membership. And for self-care behavior, for every 1 unit increase in self-care behavior, there was a 2% decrease, in odds of having medium versus high membership. It's a lot of words, and I will break this down a little bit more in the discussion. So for the final aim, here, we explored the relationship between class membership and psychosocial outcomes, including quality of life and depression symptoms. And we achieved aim 3 using these 4 steps here. Here are the results. So again, we started off with bivariate analyses, and it revealed these following covariates here that had a significant unadjusted relationship to the outcomes. And then I used these in subsequent multivariable linear regression models. But importantly, specifically, these are the bivariate relationships between resilience class membership and each of those 2 outcomes. So on the left, you'll see the quality of life model. You can see resilience class increases, so does a person's quality of life. And then on the right is the depression symptom model, and you can see that as resilience class increases, symptoms of depression decrease. When you put resilience class in a model with other important covariates, we find that resilience class remains significant. And in fact, it's the strongest contributor of quality of life as quantified by the F ratio. So together, this model predicts almost 37% of the variance in quality of life. When you look at the differences in quality of life score by resilience class, each difference is statistically significant, and the difference between high and low resilience class and medium and low resilience class both have very, very large effect sizes. The effect size of the difference in quality of life scores between high and medium resilience is moderately large. So next, for symptoms of depression, here again, you put resilience class in the model with all those other important covariates. We still find that resilience class remains significant. And once again, it's the strongest contributor of depression symptoms as quantified by that F ratio. So together in this model predicts about 30% of the variance in symptoms of depression. When you look at the differences in depression symptom scores by resilience class, each difference is again statistically significant, and the difference between high and low resilience class has a very large effect size. The effect size of the difference in depression scores between medium and low resilience is large, and the effect size of the difference between medium and low is small. All right, so now let's go back and try to put this all together. We started off by using data from the SCIMS national database. to see if latent subgroups of individuals exist based on their patterns of responses to the SciQual resilience short form. We fit 2 to 8 class solutions and found the sharpest decline in fit statistics when moving from a 2 to a 3 class solution, which indicates the 3 class solution might be optimal. The 3 class solution also had strong response loadings, which indicates high, medium, and low resilience classes. The 4 class solution provided some more nuanced information about moderate resilience responders, but it was not sex invariant. Since the 3 class solution was sex invariant and age invariant, it was selected as the optimal solution. So the final 3 classes were named high resilience, medium resilience, and low resilience. So once we identified those classes, we wanted to see which factors were related to those classes. We found that males were more likely to belong to a higher resilience class compared to females. And in the literature, the association between sex and resilience among people with spinal cord injury is actually mixed. So for example, 2 studies using the CD risk found no significant influence of gender on resilience, while another study with Nepalese participants reported lower resilience in females, but the authors attributed this to cultural factors in a patriarchal society. Our study is the first to use the SciQual resilience measure and to actually observe significant sex differences. So this presents a novel finding that may be a result of using the latent classes to describe the resilience data rather than using the total score. And importantly, this implies that being female may be a risk factor for low resilience, and it should be targeted for intervention accordingly. Age. Older participants were more likely to belong to a higher resilience class. And this finding contrasts with some literature, such as Driver and team, who found that age was related to resilience, but only at the time of injury. In contrast, Victorson and colleagues found no difference in resilience by age groups. It may be that being older when injured is what actually predicts resilience, or it could be that over time, one becomes more resilient due to life experiences and or the setbacks that may be related to spinal cord injury. Employment status. Unemployed participants were more likely to have lower resilience class membership. So this may imply that working or going to school is a protective factor related to resilience, and that being retired, either age or disability related, has no bearing on resilience class membership. Previous studies have shown that employment is related to resilience in unadjusted models, but then the relationship tends to disappear when other variables are considered concurrently. Employment is a salient outcome for people with spinal cord injury, and unemployed individuals represent a group of people who presumably have the intention to work either now or in the future, because they don't yet define themselves as retired, either age or disability related. So these results underscore the importance of programs that really facilitate reentry into the workforce, like your VOC rehab programs, and that employment may foster a sense of resilience or overcoming after a life-changing injury. It's also possible that people who are working following injury are able to do so because they're inherently resilient. So we really need longitudinal studies to understand the temporal relationship between employment status and resilience. But nonetheless, our results provide evidence that people with spinal cord injury who are unemployed represent another potential group to target for intervention. Time since injury and social support. So both of these were significantly related to resilience class membership. As time since injury or social support increased, so did the odds of belonging to a higher resilience class. And these results may indicate that social support and time since injury are both protective factors that are related to resilience. It also may be possible that people who have high social support are more resilient people. And again, we need longitudinal studies to tease out these relationships. Time since injury, on the other hand, is not a modifiable factor, but it could certainly be used as a screening variable to identify people at greater risk for low resilience. And given our results on age and resilience, it's possible that age moderates the relationship between time since injury and resilience. But this study that I conducted did not consider interactions when identifying factors related to resilience. So we recommend that future research considers the interplay between resilience and other related factors. Self-care behavior. It was also significantly associated with resilience class membership, such that people with a greater ability to complete self-care activities had increased odds of having either the high or the medium resilience class membership. So findings in this area in the literature are mixed. Our results provide additional evidence that the two constructs may indeed be related. Self-efficacy, or one's belief in their ability to achieve a desired outcome, likely contributes to this relationship, but self-efficacy was not measured in the current study. So future resilience studies, it's really important to include self-efficacy as a moderating variable that could influence outcomes in this way. Regardless, our results suggest that self-care behaviors may be used as an indicator of resilience, and it could also be used as a modifiable factor in a resilience intervention. So by possibly introducing devices or equipment that assist with self-care activities, it could increase the ability to complete these activities, thereby resulting in a higher sense of resilience. And finally, having good self-reported health status was strongly related to higher resilience class membership. In qualitative work, Dr. Mondin, who is a moderator, identified a new resilience theme among people with spinal cord injury, which is perspective. And this may provide a little context to our findings. It may be that resilient individuals rate their general health relative to experiencing their initial injury. So in other words, compared to experiencing a life-altering injury, their general health is pretty good now. The association between self-perceived health status and resilience has not explicitly been studied in spinal cord injuries. So these findings present a foundation for future research on the topic. In other aging and medical populations, however, those with a better self-perceived health indeed report higher resilience, and that supports future inquiry and provides some evidence that self-perceived health status should be considered in resilience-related screening and intervention development. So together, these results provide valuable information about potential risk factors and protective factors associated with resilience. Sex, employment status, age, and time since injury were all significant factors related to resilience, and researchers and clinicians can use them to identify people at risk for lower resilience and whom to target for treatment. Health status, self-care behaviors, and social support were also significantly related to resilience membership, class membership, which represent modifiable factors that could be targeted to improve resilience following spinal cord injury. Next, we wanted to understand the relationship between resilience classes and psychosocial outcomes. So using the multivariable linear regressions, we confirmed our hypothesis that resilience class membership is significantly related to quality of life and depressive symptoms. And it was the most significant factor for each. For quality of life, we found that the highest resilience class was associated with higher quality of life, the lowest resilience class with lower quality of life, and then that medium class fell right in between. The factors in the model explained almost 37% of variance in quality of life scores. And resilience alone, the class membership, accounted for 14% of it. The difference in quality of life scores between resilience classes was substantial, and that's indicated by those very large effect sizes we found for each of the comparisons. For instance, the difference in average quality of life score between the high and the low resilience class was 8 points, and that goes with an effect size of 1.9. The difference between the medium and low resilience class was 5 points, and the effect size there was 1.1. So there's no established, there is no established minimal clinically important difference for the quality of life measure we use, but a change of 1 standard deviation has been recommended as a clinically meaningful change. So given that 1 standard deviation is equivalent to an effect size of 1, our results indicate that improving one's resilience class may actually result in meaningful increases in quality of life. For the depression symptoms, we confirmed our hypothesis that higher resilience was associated with fewer depressive symptoms. Our model explained almost 30% of the variance of depression scores, and resilience alone accounted for 12% of it. Resilience was the strongest predictor of depression symptoms, which is consistent with other studies that found psychological and social factors contribute more to depression outcomes than social or socio-demographic factors. The differences in PHQ-9 scores between resilience classes were also sizable. And again, this was indicated by those large effect sizes we found for each comparison. For instance, the difference in PHQ-9 between the high and the low resilience class was 5 points, and that's an effect size of 1.2. The difference between the medium and low resilience class was 3 points with an effect size of 0.8. So there's varying recommendations for a meaningful change score on that PHQ-9 measure, but the developer of the measure suggested a 50% decrease and a total score of less than or greater to 9 is clinically meaningful. So given our results, increasing a person's resilience class could represent a clinically meaningful decrease in depressive symptoms. So together, these findings underscore the importance of resilience in achieving positive outcomes for people with spinal cord injury and highlight the need for interventions targeting resilience to improve quality of life and reduce depressive symptoms. So I know these findings are super compelling, but there's always limitations that need to be considered when you are interpreting results. So our final data set was limited to people with a recent follow-up interview and complete resilience data. So as a result, our final sample had a greater proportion of younger people, people with incomplete injuries, people who are married, people retired due to disability, and people working or in school. People who were lost to follow-up or who declined the resilience questions may differ from those who were included in the analysis, and these differences may be meaningful, which can certainly impact the study results. These data are cross-sectional, so we can't infer causality or directionality of the relationship between resilience classes, the predictors, and the outcomes. So we really do need to look at this longitudinally to tease out those relationships. Response bias is always a significant limitation. So this bias can arise from a consistent tendency to answer in a particular way, which poses a real threat to the validity of these findings given the use of latent class analysis. And then finally, self-efficacy is not included in the SCIMS dataset, which is something that comes up consistently in the literature that is related to resilience. So our study produced a model that categorized response patterns into latent subgroups, and we named those high, medium, and low resilience classes. So we plan to share the code openly so other researchers can apply the same methodology to their data sets using posterior probabilities to assign class membership. It's essential for future researchers to validate this classification system across various populations to make sure it's reliable and it applies in diverse contexts. Researchers should also consider using class membership as a moderating variable to understand the impact of interventions on outcomes. Also, we identified factors associated with each subgroup, which allows researchers to know who to target for intervention based on risk and protective factors, and which factors are actually modifiable so you can inform the development of an intervention. The resilience classifications can also be used by clinicians to quickly identify individuals at risk for adverse outcomes and to guide personalized treatment approaches. Oh, and that's the end. Thank you. And I am open for questions.
Thank you, Angie. And we will open it up to questions for Angie. You can feel free to type them in the Q&A. And I'm sure Angie would be happy to respond to them live, or if you have questions that you don't want to ask in front of everybody, feel free to email Angie. She has her email address up there.
I would be happy to email slides. If you shoot me an email, I will send them out to you, not a problem.
So Angie, what's the next step for you?
That's a great question. So I want to look at this longitudinally. So the SCIMS data set is limited to this question, the resilience items only being asked at one time point. It's a new measure that we just started asking participants in the last cycle. So once we get the next data set, the publicly free de-identified data set, we should have, for at least a sizable portion of people, 2 or maybe 3 time points in which we can start to look at resilience over time. And I can take these classes and look at trajectories over time. So that's kind of my next step, to see if this holds true and if there really are those temporal relationships with outcomes.
Thank you.
You're welcome. If you don't think of anything now and you think of something later, do feel free to email me. I'm happy to answer questions offline.
Somebody put in the chat, will link to slides be available? So we could email those out, Dan, maybe? Or Angie, I could put them on the website, maybe.
Oh, yeah, sure. That works.
Yep, Angie offered to email them out, but I can also send them with the CME information when we're done.
Okay, fantastic. And I can also put them on the MinSCIMS website, which is, I can't think of what the website is off the top of my head. minscims.umn.edu, I believe. And then somebody asked, is there a way to, Kathy Allen asked, she's a member of our community advisory board, is there a way to include level of injury?
Yeah, that's a great question, Kathy. Thank you. So as part of the injury characteristics, I included a variable of completeness, so incomplete versus complete. And I was able to categorize that variable by using the NSCI exam scores at rehab discharge. So I did include it, and it was not significant.
Thank you. That's the case in a lot of psychosocial research. We often look to, I think, level of injury to be associated, higher level injury, poor outcomes. And I think part of that comes from an ableist perspective of, if you have a higher level injury, you must have poor outcomes. But what the data shows is that it's actually more about complete and incomplete. And it's actually typically those with incomplete injuries who have poor psychosocial outcomes. So in terms of things like they might have worse depression scores, higher scores of anxiety, things like that. And the thinking is that, we don't know for sure, but some of the hypotheses are that people with incomplete injuries don't really know what their final recovery will be, and also have a more difficult time finding their sort of disability identity, because they feel like they don't fit in to a lot of spinal cord injury communities if they can ambulate. So yeah, it's just kind of interesting. That's one thing we always look at in a lot of research that Angie and I have done, and other psychosocial researchers, and level of injury doesn't tend to come up as significant. Sorry, Angie.
No, it's fine. Great question, Kathy.
All right. Well, thank you, Angie, for presenting today. And I gotta go back over to my script now. Our next presenter will be on October 3rd at the same time. And it will be Dr. Ryan Solinsky, who will present on autonomic dysfunction after spinal cord injury. So thank you all for attending today's grand rounds. We encourage you to ask Angie any questions through email, or pull her slides off of the website, or get them from the email that is sent out. Happy to answer any questions. She's happy to answer any questions. The recording of this webinar will be posted soon on the MinSCIMS website, and Dan put that link in the chat. Thank you, Dan. And we put these on our YouTube channel, so you can, if you've missed grand rounds in the past, you can go back and look at the ones you may have missed. And at the end of the webinar today, there will be a brief 3-question survey that will pop up. This will ask questions about your satisfaction with the grand rounds presentation, and also give us ideas for topics you might be interested in hearing about in the future, so that we can tailor them to your interests. So thank you again for attending, and have a great rest of your day.